in Seattle, unusually sunny and very hot, and we are not used to that. So this is actually a very good excuse to be staying indoors and learning on a Saturday. And we really appreciate you joining us. So as many people may know, that this is a new series that we just started. This is our second session in this series. The purpose of this series is to have a discussion about the best practices, the best literature out there, and the gaps in the literature on various immune-related adverse events. Our first session was on colitis. Dr. Mimi Wong presented, and she did a fantastic job making us aware of the latest and greatest on colitis. And that actually stimulated a lot of discussions as to how we manage things at our institution. And one of the goals of this is to obviously learn from each other, but also just get a conversation going on how best should we be managing these immune-related adverse events, which require multidisciplinary collaborations. So it's important to be having those conversations regularly. And our goal is to keep having these periodically every other month or so, and invite experts in the fields, and again, have some cross-fertilization of ideas. So just a few housekeeping things. We will be recording this session. Please put yourself on mute if you're not speaking. You are, whatever you're comfortable with, if you're comfortable, please have your camera on, especially when speaking. It does promote engagement, but if you're not comfortable, that's perfectly fine. Questions are welcome. We have 1.5 hours or so. And Jarushka, I saw that you have slides, 29, 30 slides. So it's not a whole lot of slides. The purpose is to really have a discussion. I would say feel free to interrupt, ask questions in between, while we are discussing that. That's perfectly fine. You can again ask using the mic, or you can just put it in the chat, and a couple of us can monitor the chat room. Also, if you don't mind, please put your name in the participants list. Actually, we got some feedback from our first session. The feedback was overwhelmingly positive. Everybody loved the discussion and the back and forth. We had asked if people would like to get CME credit, and I think there was an overwhelming yes to that. We are spending our time on Saturday. If we can get some credit for it, that's nice. So the hardworking team at SCCA has made that happen in a few weeks. So thank you for that. And if you do want CME credit, you will get an online survey that you will need to fill. If you don't receive this, there's the email over there, cme@seattlecca.org. You have to do it within 2 weeks. And again, at the end of it, when you get the feedback survey, please share your feedback with us. If you have any suggestions for future topics or speakers, please feel free to let us know. So here are our disclosures. The talk today has been reviewed by an independent reviewer. So we do not foresee any potential conflicts of interest when it comes to the content of the discussion today. Next slide, please. So with that, I would like to introduce our speaker. Dr. Jarushka Naidoo is a consultant medical oncologist at Beaumont Hospital, Royal College of Physicians of Ireland. When we invited you, I think you were at Hopkins, and this sounds like a recent move. But Jarushka has probably the most interesting path to medical oncology that I have come across. While I was looking up her bio on the web, I learned that she was born in South Africa, and she had a very interesting childhood. She was a childhood TV star and presenter in South Africa for many years. And somehow, somewhere, she got interested in biology And thankfully for our patients, she became a medical oncologist. She did her medical training in Ireland, followed by residency and also, I think, oncology fellowship over there. And then she moved to the US, did an advanced fellowship at Memorial, and then she became faculty at Johns Hopkins for many years. And somewhere along the line, she got interested in immune-mediated pneumonitis. So I'm pleased to have Dr. Naidoo join us. And Jarushka, please start by telling us how did that switch happen? And how do you, when you look back, how was that experience as a TV personality?
Yeah, interesting and colorful story. I agree. So I think anybody who's a medical practitioner will appreciate that there is a good bit of overlap between the medical textbook understanding of a situation and the interpersonal skill of being an oncologist, being able to work with a variety of people, understanding their stories, understanding where they come from, makes someone, I think, a more effective team builder, team member, and physician. I think really I've had two loves in my life. I've had biology and I've had drama, and lung cancer brings both together. So yes, I actually did. I went to drama school in London and did Shakespeare for a year before I went to medical school, and I was a TV presenter in South Africa for many years. So interesting history. I'm South African. And for those of you who might know the history of South Africa, my parents would have lived through the apartheid era. And interestingly, Ireland was one of the very few countries in the world that trained South Africa's non-white people as a stand against apartheid. So my mother was the first radiologist in South Africa, female person of color. And I had family in Ireland and decided I want to continue the tradition and do medicine in Ireland. So I decided to embark on a career in medicine, continued my love of drama sort of concurrently, and became very interested in oncology very early because I saw that you needed to have both skills in medicine, a love of lifelong learning, and a love of communication. And that's what I think this field brings to all of us. And, the Irish are loved by many. And we have a scholarship program by which one Irish person is sent to Memorial every year, and I was that person in 2013. So I went to Memorial at a time when immunotherapy was coming of age, and I worked with Jed Walchok and Naya Rizvi on immunotherapy in lung cancer. And I'll show in my talk, the very first patient I saw in clinic with Jed had PD-1 pneumonitis. And that sort of, as many of us, shaped my career in this field. I ended up getting a job at Hopkins and doing a lot of work in this space, and continuing the love of talking, as you can see already, and drama at the same time. So I might just share my screen and start talking a little bit about this field, if that's okay. And thanks to Dr. Bhatia and the team for your very kind invitation. So yes, I was an assistant professor at Hopkins for 5 or 6 years. And then there was an opportunity to return to my new hometown, or my second hometown of Dublin. And now I am a consultant medical oncologist, is the term for assistant or associate professor here. And I'm actually the national lead for lung cancer. So I would develop the clinical trials portfolio for the country. And that is another role that I'm in. So great opportunity to come home and to bring the expertise from Hopkins and MSK back. So focusing a little bit on immune-related pneumonitis. So I'll walk you through, as I said, week 1, in fact, day 1 of immunotherapy clinic with Jed. This is the CT scan of the very first patient I saw in clinic, who was at the time enrolled on an early clinical trial of the PD-1 inhibitors with lung cancer. And the patient presented with a worsening cough or shortness of breath. And Jed said, "Jarushka, what do you think this is?" And so a career was born. There are two other examples of other clinical cases that came to clinic within week 1 that also spawned other interests in immune-related adverse events, a patient who had a blistering skin rash and another with a swollen joint. And what these ended up being were PD-1 pneumonitis, bullous pemphigoid, and inflammatory arthritis, which I've since published on with colleagues in the various specialties. So focusing in on pneumonitis, as most of you know, pneumonitis, the definition of this is a focal or diffuse inflammation of the lung parenchyma. And at the time, there was very little known about it in those early weeks of clinic. And what we did and what we still continue to do is we do some general imaging of the chest, usually with a contrast-enhanced CT to rule out pulmonary embolus, a standard infectious evaluation, and I use the term standard in inverted commas because this is different depending on where a practitioner or a patient may present. And then in some cases, we may consider doing a bronchoscopy with or without bronchoalveolar lavage to truly rule out alternative causes. As we know, most patients are treated with corticosteroid, and in some cases, additional immunosuppression is required. The most common that has been used to date has been infliximab based on colitis. And really that very first case, and in looking after many patients with this complication, has raised a number of open questions. First of all, the very early questions: what are the clinical features of PD-1 pneumonitis? What do these patients commonly present with? And how do we know they have pneumonitis as opposed to other presentations, since we know pneumonitis is a diagnosis of exclusion? Second, what are the risk factors? Is there anything in particular we should be looking out for? How does pneumonitis behave? When a patient develops pneumonitis, what is the likely trajectory or natural history of this toxicity? The mechanisms, why is this happening in selected patients versus others? And of course, as I touched on as well, what are the optimal treatments when we think about corticosteroids or even beyond that? So from here, and seeing these patients and having these questions at the forefront of my mind, I undertook a comprehensive set of studies to try to elucidate some of the answers to these questions. So the very first paper that we published in the JCO in 2016 was a collaborative study between Memorial Sloan Kettering and the Melanoma Institute of Australia, who were treating a lot of patients with checkpoint inhibitors in those early days. And in this study of over 400 patients at the time, mainly with lung cancer and with melanoma, we identified 43 cases of PD-1 pneumonitis. And what we identified was, as you see on the left-hand side, that the majority of cases reassuringly have low-grade toxicity, 40% grade 1, 33% grade 2, but there was still quite a high proportion of high-grade events, 23% grade 3, 2% grade 4, 2% grade 5. And if we look at the split between monotherapy and combination therapy, we see that roughly there appeared to be a slightly even split, but with a predominance of combination approaches for maybe some of the higher grade events. What are some of the salient clinical features that we identified in this, the very first comprehensive analysis on PD-1, PD-L1 pneumonitis? So one of the most important elements of pneumonitis that is different to other immune-related toxicities is this variability in terms of timing of onset. In many studies across many tumor types, we appreciate that most immune-related adverse events will occur in the first 3 months of immunotherapy. But what this study showed, and what has been confirmed in subsequent studies, other series, other meta-analyses, is that pneumonitis can occur really any time during a patient's treatment journey, and sometimes even after they've completed immunotherapy. So in this particular study, we saw that patients developed pneumonitis anywhere from 9 days to 19.2 months after the start of immunotherapy. What we did see was that the higher grade of events seemed to coalesce early in the treatment, but there were still selected events that could occur late. And in this study, blue indicates all patients, yellow indicates the low grade events, and gray indicates the high grade events. Another very salient feature of this study, which was subsequently confirmed and elaborated on in further studies, was that pneumonitis is not all created equal in terms of radiographic appearances. So in the Memorial Sloan Kettering subset of patients, we had both baseline and serial radiographic imaging on all patients who developed this complication. And what we saw was that radiographically, pneumonitis may present as an organizing pneumonia type, which for all intents and purposes can look like metastasis, a classic ground glass appearance, hypersensitivity pneumonitis, which can occur bilaterally, interstitial changes and with reticulonodular change that can sometimes look like sarcoidosis, or pneumonitis not otherwise specified, which is essentially a grab bag of all of these appearances. What we also identified was that pneumonitis may be stratified according to the proportion of the lung parenchyma involved, where mild was defined as less than 25%, moderate, 25 to 50%, and severe, more than 50%. And I should linger there for a bit. What we did identify was that patients with lung cancer appeared to preferentially develop the organizing pneumonia subtype of pneumonitis, and that this was a statistically significant finding, and that patients who had moderate to severe radiographic pneumonitis, so greater than 25% or greater than 50% of the lung parenchyma involved, were associated with the need for additional immunosuppressive therapy. So really some radiographic features there that I think are important to highlight. Since then, some investigators have done further work to elucidate these subtypes. I would alert you to a really excellent radiologist called Mizuki Nishino, who did some of the foundational work in this, published in the New England Journal of Medicine, CCR, and others. And she has taken the lead on developing some newer Fleischner criteria for the identification of subtypes of treatment-related pneumonitis, and they are very similar to these. Another very important aspect of this, and of course you can see variety is the order of the day, this is one of the only studies that was able to look at pathologic features of PD-1 pneumonitis. And again, we see variety. So we saw a subset of patients that developed cellular interstitial pneumonitis, some this organizing pneumonia subtype, and then as some of us unfortunately have seen, diffuse alveolar damage, which is the histologic subtype associated with ARDS. We also saw certain pathologic features embedded within these subtypes, such as the formulation of granulomas, presence of eosinophils, and in some cases, vascular recanalization. From there, my journey took me to Hopkins, as I have highlighted, and I formed a really excellent collaboration with an interstitial lung disease pulmonologist at Hopkins called Karthik Suresh. And he and I undertook a number of studies looking at some of the subsequent questions relevant to pneumonitis. And one of these questions was, what are the risk factors for pneumonitis? Is there anything in particular that we can use to risk stratify this group? In the early Memorial study, we identified that prior chest radiation and smoking status were associated with the development of pneumonitis. So those who are current or active, former or current smokers, and those who had received prior radiation were risk factors. In this study, interestingly, we did not see the association with smoking, but what we did see was in the lung cancer population that tumor histology may matter, and that patients, depending on histology, particularly squamous and other subtypes, appear to be associated with a higher risk for the development of pneumonitis. And this is a phenomenon that was seen in some of the early studies in lung cancer of the PD-1 inhibitors. I think a very important aspect of diagnosing and managing patients with pneumonitis is these different diagnostic considerations. We're often asked to be able to identify pneumonitis against common alternative diagnoses, such as infection, right heart strain or pulmonary hypertension, lymphangitis carcinomatosa, and rare infections such as fungal infection. And really, the cornerstone of this, as has been mentioned by Dr. Bhatia in the context of colitis, is creating a multidisciplinary discussion. And some of the common things that need to be taken into account, for example, are a history of interstitial lung disease, or a worsening of known interstitial lung disease that may be related to other features such as prior radiation, autoimmunity, occupational exposure, and of course the radiographic pattern. Worsening of comorbid conditions such as COPD, other cancer-related features that may factor in to the development of pneumonitis, such as EGFR inhibitors, and then of course the cardiorespiratory status, so assessing a patient's DLCO, 6-minute walk test, signs of heart failure. These may all masquerade as pneumonitis and are important in this discussion. So the second question that comes to mind with regard to pneumonitis is the natural history. How do all of these patients do once we give them corticosteroids or additional immunosuppressive agents? What can we expect? So in the early memorial study, we saw that around 80% of patients, and slightly higher, will have a clinical improvement or complete resolution with corticosteroids. However, in a subset of patients, the natural history may differ. And in a study that Dr. Suresh and I led, we identified that a subset of patients, namely 2% of patients with lung cancer and melanoma, appeared to develop what we call chronic pneumonitis. Importantly, there is no consensus definition for what chronic means or what chronic immune-related adverse events mean. But in the context of this study, we defined chronic as pneumonitis that lasted for more than 12 weeks post-discontinuation of immunotherapy and required long-term immunosuppression, meaning immunosuppression lasting greater than or equal to 12 weeks. If we look at the NCCN guidelines, the recommended steroid taper is 4 to 6 weeks. So this would constitute double or nearly triple the duration of standard immunosuppressive therapy. And what we identified in a series of patients who developed this chronic toxicity at Hopkins was some characteristic features on invasive testing. In a subset of patients who developed severe pneumonitis that developed a chronic course, we were able to do serial bronchoscopy to truly diagnose that this was pneumonitis rather than infection. And what we identified was that patients who developed pneumonitis appeared to have a BAL lymphocytosis that persisted despite the treatment with corticosteroids. In a subset of patients, we were also able to evaluate pathologic samples from lung cancer tissue or lung tissue that was obtained at the time of bronchoscopy. And this was evaluated both by H&E and by multiplex immunofluorescence. And what we identified was that morphologically, it looked like these patients developed bronchoalveolar alveolitis obliterans with an infiltration of CD8 high T cells in the pneumonitis tissue. And this really fits with the hypothesis that the mechanism, or points to the fact that the mechanism of chronic pneumonitis may be mediated by activated T cells. This, of course, naturally leads into our next discussion of what could be the mechanisms that underlie the development of pneumonitis. So taking a step back in terms of all of the different immune-related toxicities, I would point you to a great paper published by Mike Postow and colleagues looking at the different mechanisms of immune-related adverse events. And again, variety is the order of the day. And we see that selected immune-related adverse events appear to be mediated by the generation of autoreactive T cells. Others appear to be B-cell autoantibody mediated. Selected immune-related adverse events appear to be cytokine mediated or mediated by soluble factors within the tumor microenvironment or the microenvironment of the immune-related toxicity. And there may be target expression of PD-1, CTLA-4, and the relevant immune checkpoints in the tissue affected by the immune-related adverse event. Of course, no talk on immunotherapy or even immune-related adverse events now is complete without mentioning the gut microbiome, as well as HLA or germline genetics. And what we see is that the different immune-related adverse events appear to be associated with these different mechanisms. And pneumonitis has been linked to both T-cell mediated and cytokine mediated mechanisms So we at Hopkins attempted to look into this as well. And how we approached this in our study was we had a neoadjuvant clinical trial of upfront immunotherapy with nivolumab that was active and ongoing in early stage lung cancer at the same time as many of our pneumonitis studies. So in this study of neoadjuvant nivolumab for early stage lung cancer that was published in the New England Journal of Medicine, a subset of these patients had BAL that was obtained at the time of a bronchoscopy perioperatively in patients who did not develop pneumonitis. So these acted as our 6 controls. And we compared these to the BAL features of 12 patients who developed PD-1 pneumonitis that was subsequently both clinically and pathologically confirmed. And what we did is that we examined the cell differential of the bronchoalveolar lavage fluid from both the patients who developed pneumonitis and the controls. And we also sent these samples for real-time multicolor flow cytometry and cytokine analysis. So this is a little schema of the findings from the study. And broadly from the BAL cell differential, we identified, similar to our chronic pneumonitis patients, that in all patients with pneumonitis in this study, we saw a predominant BAL lymphocytosis. Looking specifically at the features of the patients who developed pneumonitis versus controls, based on the multicolor flow cytometry data, we identified an increase in T central memory cells that express CD62 ligand, and a subset of cells that were high in TNF alpha and interferon gamma, as well as CD8 positive or activated T cells. And this would underscore a potential benefit for interferon gamma, TNF alpha targeting approaches such as, for example, infliximab. But interestingly, we also saw a separate subset of populations within the BAL of certain subsets of these patients that appeared to have the presence of myeloid cells, including CD11 beta and IL-1 beta. And really, this indicates that there is an increase overall in pro-inflammatory cell subsets, as well as endothelial adhesion markers that may mediate different types or different natural histories of PD-1 pneumonitis. Looking specifically at the cytokine profiles, we see here that overall there was a skewing of the alveolar component with an increase in IL-1 beta and IL-6 in certain subsets of the population versus others, indicating once again increase in T cell and macrophage-based or myeloid-based inflammation. So one of the last questions that had come up in the original studies on how to treat pneumonitis was, can we do better beyond steroids? So what we see is that really there has been no winner thus far in terms of optimum immunosuppressive therapy for patients who develop pneumonitis that does not clinically improve with corticosteroids. In the original studies, this was purported to be around 10 to 15%. And in more recent studies, it appears that this subset of the population is probably smaller than that at about 2 to 5%. In the early studies, particularly the study that we led at Memorial Sloan Kettering, we saw that the patients who were treated with infliximab appeared to have poorer outcomes. And those patients appeared to die either from pneumonitis or infection related to the deep immunosuppression conferred by infliximab. Colloquially, we had seen that intravenous immunoglobulin, which has been effective in other interstitial lung diseases such as IPF and other immune-related adverse events such as neurologic toxicity or hematologic toxicities, may actually be of benefit in the subset of patients, and of course does not confer the same risk of infection. One particular challenge with trying to innovate in this space is that bronchoscopy is not routinely done for these patients, and therefore the ability to truly discern what is pneumonitis between other maybe low-grade infections or progression can be difficult if a bronchoscopy is not mandated. So in order to inform how we may do better with steroid refractory pneumonitis, this is a paper written by a stellar medical student, Arnika Balaji, who is now an internal medicine resident at Hopkins and worked with me very closely on this study and others. And in the study, she looked comprehensively at a series of patients who had developed steroid refractory pneumonitis. And we separated those into patients who developed this phenomenon that had a clinical improvement versus those who did not have a clinical improvement. And really, as you can see, in the patients who improved, we see radiographic improvement in the interstitial changes, whereas those who disimproved generally had worsening radiographic features. She looked at a comprehensive series of 12 patients who had developed immune-related steroid refractory pneumonitis. And in this figure, which outlines the clinical course of these 12 patients, I would alert you to the black lightning bolt, which indicates, unfortunately, death, either from immune-related pneumonitis or its complications. And what we see is that patients in this series received either IVIG, infliximab, or a combination of both, and that in both patients who received infliximab alone or those who received combination, these nearly universally had a poor outcome. However, in a subset of patients who were treated with IVIG, patients had a good clinical outcome in that their pneumonitis either stabilized or improved. But unfortunately, we see that in these patients, most of them did die, but usually from cancer-related outcomes rather than from pneumonitis. So building on this, we propose to develop a clinical trial to assess pneumonitis response, comparing the two major immunosuppressive approaches that have been used for steroid refractory pneumonitis, namely infliximab or IVIG. And we define pneumonitis response as an improvement in arterial oxygenation measured by the PF ratio at 28 days. Other outcomes we aim to look at were clinical, functional, or radiographic improvements at 14 days or 28 days after immunosuppression, to assess the incidence of a fatal outcome at 28 days and the rate of infection, since we know that this was associated with infliximab treatment. We also aimed to examine lung tissue, BAL, and serial blood specimens in this study in order to identify the mechanisms of steroid refractory pneumonitis. This is a schema of the study. The study is called EAQ-172, Exploring Optimum Immunosuppression for Steroid Refractory PD-1 or PD-L1 Pneumonitis. And this is an ECOG study for which I am the study chair and is currently open at over 15 centers across the US. Broadly, the inclusion criteria: patients need to have grade 2 or greater PD-1 pneumonitis with a background of PD-1 therapy for either a solid tumor or hematologic malignancy. Patients may have received any PD-1 or PD-L1 agent, and we define steroid refractory pneumonitis as pneumonitis that did not improve after 2 to 10 days of high-dose prednisolone, defined as 1 to 2 milligrams per kilogram per day. Importantly, we mandate in this study that patients will have a pathogen-negative bronchoscopy within 2 weeks of enrollment that does not show any evidence of active infection or progression of cancer if a patient has lung cancer or metastasis in the lungs. We use this study to perform a series of baseline analyses, including a high-res CT of the chest and patient-reported outcomes, as well as pulmonary function tests. And patients are randomized to either infliximab or IVIG, followed by a standard steroid taper. The primary endpoint of the study is an improvement in arterial oxygenation, defined as the PF ratio from an arterial blood gas 28 days after investigational therapy. So moving on from there, after 5 years of work on this topic, what have we learned, or what steps can we take to innovate in this space? Well, I think how the field has changed is that immunotherapy has come of age for so many different tumor types. And what we're seeing now, and this is the 5-year survival data, and now we've seen 6.5-year survival data in melanoma for ipi/nivo, is that patients are surviving from immunotherapy. Particularly in melanoma, we're now seeing a 60% 5-year survival for these patients. But importantly, we see that 96% of them have an immune-related adverse event and nearly 60% a high-grade toxicity. And this isn't just happening in slightly rarer cancers like melanoma, it's also happening in common cancers like lung cancer. And as you can see here, pneumonitis is one of the top offenders, particularly in patients with lung cancer. Here I reference Mimi Wang's data in the colitis space, we recognize that early recognition of immune-related adverse events and intervention early affects outcomes. By identifying pneumonitis and other immune-related adverse events, these patients tend to do better. We also understand in the last number of years that some of these toxicities may not occur alone. And we now appreciate that there may be immune-related adverse event overlap syndromes, such as myocarditis, myasthenia gravis, and myositis, underscoring the need for having multidisciplinary teams. So in our multidisciplinary team effort, which I'll highlight next, we have seen that up to 15% of patients may have immune-related adverse events that occur together. So this is a manuscript very recently that I also published with an excellent medical student who is now a resident at Hopkins called Bharavi Shankar. And what we looked at here was, are there any other immune-related adverse events that occur together besides the myositis, myocarditis, myasthenia overlap syndrome? And really what we saw here in our Hopkins experience that was coalesced with the experiences of several other institutions is that certain toxicities may occur together, but it appears that the common toxicities occur together, such as pneumonitis and thyroiditis, hepatitis and thyroiditis, dermatitis pneumonitis, and dermatitis thyroiditis. However, no patterns were seen in the combinations. These were the patterns that appeared to emerge in people getting PD-1 or PD-L1 monotherapy. What's also really important to note is that those patients who develop multi-system immune-related adverse events appear to do better from immunotherapy. And in this analysis, that was controlled from a time-dependent perspective, meaning that we controlled for the number of doses a patient had received and analyzed this using time-varying covariates. It also appeared that there is a sequential gain in both progression-free and overall survival with the number of immune-related adverse events that a patient develops. In those patients developing more than 2 immune-related adverse events, the hazard ratio for progression-free survival benefit was 0.38 and 0.56 for overall survival, and both were statistically significant. However, this may not apply to every single toxicity. And what we've seen is that pneumonitis may not always play well with this. So this is an interesting statistical analysis undertaken again by Karthik Suresh, Kevin Soter and colleagues, identifying that in patients who have checkpoint inhibitor pneumonitis who then progress, no checkpoint inhibitor pneumonitis who progress to checkpoint inhibitor pneumonitis, how do they do in terms of their risk of death versus those who do not develop pneumonitis and subsequently die. And what we see is that those patients who never develop checkpoint inhibitor pneumonitis tend to have a better survival versus those who do not develop pneumonitis. So pneumonitis may be the bad actor that is not necessarily associated with an improvement in survival outcomes. So pulling this all together, how can we innovate in the space of immune-related adverse events, or what will it take to sort of move the needle? And really, I think one of the seminal innovations that we brought forward at Hopkins was the development of a multidisciplinary immune-related toxicity team. So myself and my rheumatology colleague, Laura Capelli, proposed the development of a real-time electronic referral system by which a number of different medical specialists could come together to centralize the diagnosis of complex immune-related adverse events, such as steroid-refractory pneumonitis, that we could use this as a platform to identify some other immune-related adverse events. And also, if we wanted to do studies such as EAQ 172, this electronic referral system would allow us to accrue to these studies in real time. And really our hypothesis was, will a toxicity team assist in the diagnosis and management of these patients? And can we identify patient or treatment features that associate with these severe toxicities? So how we set up our group, which is different to how other institutions may have set this up, was we created a central group of 13 members led by myself and Dr. Capelli. And this group comprised of 8 oncologists with a large amount of clinical experience of immune-related adverse event management and diagnosis, as well as 4 oncology nurse practitioners. To our either benefit or madness, we agreed to be contactable by electronic referral 24 hours a day, 7 days a week. And we would CC the relevant medicine provider if a case called for their input. We then agreed as the chairs to send a summary of the recommendations within 24 hours, and we supported this with monthly multidisciplinary team meetings. This is a standard template for our referral and a 24-hour summary that we a template that we would supply to referring providers. Importantly, we included a disclaimer to say that the decision to implement recommendations was really at the discretion of the treating provider, and that we didn't want to get referrals for emergent cases that needed to go to the ER, such as myocarditis or others, since it would take us on average, we expected 24 hours to reply. Even if it was less than 24 hours for patient safety, we recommended that these patients be sent straight to an ER. And dovetailing back with the theme of this talk, unsurprisingly, what we identified was the toxicity for which we received the most referrals was for pneumonitis. So I'll walk you through this figure. This is a figure that shows the immune-related toxicities that underscored all of the referrals for our pilot program. And we received over 100 referrals within just 6 months of this program. So within each of these bars, the yellow subset indicates a referral which was subsequently confirmed to represent an irAE, and blue represents those that had no immune-related adverse event. And really what this shows is that pneumonitis represents a clear diagnostic dilemma, in that only a slight predominance of patients referred to us ended up having pneumonitis. So really we need to do better in terms of our diagnostic ability and accuracy in identifying pneumonitis. Interestingly, we also saw quite a high number of referrals for immune-related encephalitis. And we see here that the majority of referrals ended up not having encephalitis. So again, identifying those toxicities in which there are the greatest diagnostic dilemmas and probably the greatest need for dedicated studies. I think what this data also identifies is which groups we as oncologists need to partner with the most. So we saw the most referrals for pulmonary medicine, rheumatology, dermatology, gastroenterology, and neurology. And interestingly, we identified a new immune-related adverse event of osteitis, which was subsequently published in the Journal of Immunotherapy for Cancer. Another area which we received quite a lot of referrals for with this multidisciplinary team was in patients who had prior autoimmune conditions. So what do we know about these patients? Should they receive immunotherapy or not? Should they be managed differently in some way? So in our immune-related toxicity team, we received 10 referrals from patients with autoimmune conditions that were co-managed between the oncologist and the relevant organ specialist. And in lung cancer, we see that these patients may have a similar response rate to immunotherapy than those who don't have autoimmune conditions, but that they have a fairly high rate of developing other immune-related toxicities, or in some cases, a flare of their known autoimmune condition. But some open questions which remain unanswered are, is giving immunotherapy okay in patients who have had previous solid organ transplants, bone marrow transplants, and particularly in the case of pneumonitis for patients with prior interstitial lung disease. So in summary, I think an IO tox team type resource is something that's going to be needed depending on the local needs of different oncology providers with increasing use of immunotherapy. And really the goal of these groups is to assist investigators in immune-related toxicities such as pneumonitis, in which we need a comprehensive and multidisciplinary way to adjudicate immune-related adverse events. And I do wonder if in the future we will see a central assessment of immune-related toxicity in a similar way as we see central radiology review in many prospective clinical trials. I think the future of immune-related toxicity research and in pneumonitis is in partnership with other institutions through the development of biorepositories to study why these immune-related adverse events happen. And I would point you to a great irAE biorepository being led by David Cozono and myself through the Alliance, where we're looking at risk factors for toxicities such as pneumonitis and the identification of high-risk groups. I also think that we will see a new and increasing development of clinical trials focused on either mitigating the risk or treating immune-related adverse events such as EAQ-172. And these may be focused on vulnerable patient populations, optimization of the management of irAEs, and are likely to be the next wave. So with that, I'd like to thank all of my colleagues and collaborators here in Ireland, at Johns Hopkins, Memorial Sloan Kettering, Europe, US, and I'm looking forward to taking any questions and having a discussion on some of these topics. Thank you.
Thank you, Jarushka. That was fantastic. There are probably going to be lots of questions on various aspects of this, and we can dive into it. I cannot agree with you more about the importance of multidisciplinary, mechanisms here. And we fortunately have a pretty good pool of interested clinicians who want to be engaging in that kind of endeavor. We have several of them on the call today. I'm actually going to call out their names and just request them to introduce themselves. And talking about the pulmonary complications first. So we have Dr. Guangxing Cheng, and Dr. Visram Nair, who are our pulmonologists. Dr. Sudhakar Pipawat, who is our expert radiologist. Every time I talk to him, I learn, how to read a chest X-ray better, and he may have some thoughts about some of those imaging slides that he showed. And then we also have Namrata Singh, who's a rheumatologist, who was chatting with me on the side, saying that, oh, we need to do this for synovial fluid as well. So I think we have a lot of interest. Maybe Guangxing and Visram and Sudhakar, maybe can you just say a word or two about your interests?
Sure, I'll go ahead. First of all, thank you so much for organizing this, Shailendra. This has been fantastic. And Dr. Naidoo, that was a really wonderful overview of all the great work that you've done. That has certainly been the basis of a lot of our understanding of this. And I've been at the Hutch for almost 10 years now. And so my practice is all cancer patients, and we do see a lot of stem cell transplant patients, and I do see there are actually quite a number of parallels between irAE pneumonitis and irAEs, and what happens in chronic GVHD, which is actually what I'm focused on. But I think our pulmonary consult service, we're embedded in Seattle Cancer Care Alliance, and we serve basically cancer patients. And so we, as the pulmonary consult service, we do end up seeing quite a number of these refractory, difficult to treat cases who do require prolonged steroid courses and sometimes need to go on infliximab. And so that, I think it's really of great interest to us and our group to understand this more and potentially work, do some research in this space. So maybe I'll let Vish say more about that. Vish is my colleague here at SCCA in pulmonary.
Hey, Jarushka, Vish, great talk, fantastic talk. I could hear that again. And I have a few questions about it, but just to introduce myself. So I do primary lung cancer research, biomarker work in bronchoscopy is my current focus. So we have a research program here looking at molecular and cellular profiles, lavage fluid, more specifically aimed at detecting, prognosticating, and predicting lung cancer behavior. But I could easily see how we could pivot that into assessing irAEs in the lung. And I agree with pretty much everything you've said in terms of where we need to go moving forward. And then when we have time, Shailendra, I have a few questions about the trial. I think it's an important study. We actually discussed this internally in terms of how do we know what to do properly? It sounds like you're getting to that question. And so I have a few questions about that. Shailendra, should I pass it on to Sudhakar and then come back?
So Sudhakar, do you want to introduce yourself?
Hey, hi there. I'm Sudhakar Pipawat, and being Saturday morning, I'm not fully presentable, so that's why I'm not on the camera. And
that's okay.
Thank you very much for this wonderful talk. one of the things which we often struggle with is differentiating hyperprogression from pneumonitis, meaning, sometimes whether the disease, whether the disease has actually progressed, especially because I'm mostly involved with the lung cancer scenarios, or if there's anything, if you can give us some tips on that, that'll be great. And then, have you identified anything specific that could be targeted as a treatment option? Those were my two. And then I forgot to introduce myself. I'm a radiologist, by the way. Thank you.
So to tackle the hyperprogression question, so I think in my experience and based on the published literature, the data for hyperprogression in lung cancer is relatively limited. So we know that about 3 to 5% of melanoma patients who get treated with checkpoint inhibitors may develop hyperprogression or pseudoprogression, as per selected studies mainly from the East Coast. But the data in lung cancer is relatively limited. My understanding is the only presentation or publication really on this has been from Stephen Champiet's group in France. And the incidence in lung cancer looks to be relatively low in the sort of single digit space. So how hyperprogression has been defined so far is an increase in radiologically RECIST measurable areas by greater than 2.5 times. But I think that that's not really validated and quite contested at present. So in terms of differentiating between hyperprogression and pneumonitis, in most cases of hyperprogression, you're going to see progression in at least 2 to 3 areas throughout the body, not just the lungs. Whereas, of course, we know that pneumonitis is going to be lung specific. And this is why I harp on a little bit about the bronchoscopy element, and I know that I am not universally agreed with in this area, but I would pretty much mandate or want a bronchoscopy in any symptomatic pneumonitis patient to make sure I know what I am treating. Because a few times I have bronch these patients and they end up coming back as having a fungal pneumonia. And this has happened more often than I would care to admit. So I think that that the bronchoscopy would also be helpful in the question regarding the question of hyperprogression. I think if we do a bronch and on the BAL there are very florid cancer cells, or if we try to even do a lung biopsy of one of these areas and it's clearly lung cancer, there's no inflammatory infiltrate, then I think that really underscores that this is progression as opposed to pneumonitis. And that's kind of how I have approached it so far. I know that's not ideal. And in an ideal world, we'd want a clear biomarker. The Asians have looked at SB6 and KL6, some of these blood-based markers of ILD. My understanding is that they have not been validated in a non-Asian population. So I think that's where we would love to go. But currently, my understanding is that we don't have that data in a non-Asian population. Your second question, remind me of your second question.
Oh yeah, the second question was, did you find any specific target that can translate into treatment? Or is it just, multifactorial?
Yeah, I think from our JCI paper, which is the BAL paper I referenced, of which Dr. Suresh is the first author, there are IL-1 beta targeted agents and there are IL-6 targeted agents that are in the clinic. And we did see that a subset of these patients appeared to have different natural history compared to those that were high gamma, high TNF alpha. So one can see, and if we see these signatures recapitulated in larger studies, that one could foreseeably do a bronch, see if there are these features that are higher in one subset of patients versus another, and this may allow us to select one approach rather than the other. But in a practical sense, where we're still in a situation where not every patient is getting bronched, I think proposing that is going to be tricky. I will say in EAQ 172 alone, accrual is going to be a challenge. So far we've accrued 2 patients of 36. And one of the major issues is getting a bronch in time, getting a bronch within 2 weeks, and also maybe an institutional reticence to do this. When we know that more than 80% of patients respond to steroids, a lot of practitioners prefer to simply just start steroids rather than doing a bronchoscopy and delaying things. So I think that's something that really is a very important topic to discuss.
Can I follow up on that, Jarushka? So is there resistance from practitioners to do it because of hypoxia? Quite often, right around 4 to 6 liters of oxygen, where if we do a bronch, we can tip the patient over. Are you seeing a lot of resistance based on that, or more?
I think resistance is definitely based on that in the severe cases, but even in the cases that are not, I think in the cases that are grade 2, that are not that severe, the reticence is this going to delay my start to steroids? Because we know that steroids really work in the majority of patients, and this is a potentially fatal toxicity. So the reticence there is around scheduling. If people could get a bronchoscopy within 24 hours, I think they would do it. But most people have to wait at least 2 to 3 days to get a bronchoscopy. And then after you've already given 3 days of high dose steroids, is your bronchoscopy interpretable? Yeah. So that's, I think, the reticence in the grade 2 population. In the grade 3 or greater population, the reticence is around what you say, clinical stability. Yeah. Is this going to tip the patient over in some way? So we're kind of damned if we do and we're damned if we don't in either situation. And then the bronchoscopy doesn't happen. People get steroids. They don't get better. We bronch them later. They have fungal infection. And then we get, well, was it infection or was it pneumonitis? And the saga continues. So to me, I think the solution is get the bronch in 24 hours. And then you know what you're dealing with. But in order to do that, you need to have a close partnership with your pulmonologist. And it was easy for me to say, I sat next to Karthik. So I just say, here you go, please do the bronch now. But that, and we were studying it. So we were invested in it. But I appreciate that there are other circumstances where someone doesn't have a friendly neighborhood bronchoscopist or IP person. So I think that all of those things conspire to diagnostic difficulty.
Can I flip the question about the bronchoscopy and why to do it outside of a trial? Current practice, and does it help you not to rule out other disease, but to actually help prognosticate or predict beyond lymphocytosis, which is pretty generic, right? We see that in quite a lot of things. Is there a reason to do it if we think the patient has pneumonitis, to get extra information there in practice currently outside of the clinical trial setting?
No. And I think here we are challenged again, because in order to do that, to support if there is a prognostic or a predictive element, we need to do a study to show it.
Yeah.
So I am trying to do that. But the pushback, because grade 1 people don't need a bronch, and then it's an invasive test that you're doing unnecessarily. Grade 2 patients, you're withholding their steroid. Grade 3 patients, they're too sick. Mm-hmm. So I think that there are limitations with trying to do this. But there are certain settings where I think there is reason. And I think steroid refractory, there is a reason. We don't know what treatment is best, infliximab or IVIG. And in the steroid refractory setting, there's a real concern that it's not pneumonitis, that it could be infection. So people are more open to doing the bronch in that setting. And so that's why I started the first trial there. But interested to hear if you guys think something else.
No, I agree with you 100%. I think in modern research, these things are more difficult. 40 years ago, this would have been a much easier study to do. There's good and bad things with how we do research nowadays. But I 100% agree with you that getting a bronchoscopy early would be useful to help delineate what we need to do moving down the line.
I think the issue is, our group, I think we're all very convinced that bronchoscopy is necessary, not just for clinical care, but also for understanding. A lot of the barriers here come from the referrals to our group come to a little bit too late sometimes from the oncology side. So, you know, people are empirically treated and then they come to us when they don't, you know, many
steroid refractory.
Right, exactly. And then also if patients present to, you know, colleagues who are not within our SCCA pulmonary group, you know, other pulmonologists may not sort of be quite as familiar with kind of the issues at play here. So a lot of it is also, you know, we have to educate our colleagues and make sure that we have this partnership with the oncologists. The inpatient bit is definitely tricky, you know, like as, you know, all of us in pulmonary, we also attend in the ICU, and it is this tricky thing to see somebody, you know, who's sitting around on the floor with, you know, 4 liters of oxygen, and you know the risk that they'll end up in the ICU is pretty high. But then yes, you do want the bronchoscopy, and you know this continues to be a struggle.
Is the delay because of the because the initial treating physician is not suspecting this drug-induced, I mean this immune-mediated pneumonitis, and are investigating for infection and other things, or?
No, I think the initial delay is, let's throw everything at this, and if it gets better, then I don't need to go further. So most practitioners would give antibiotics and steroids and say they're covering infection or covering pneumonitis. And then if the patient gets better, they don't really know whether it was either. And we have an issue there, particularly on a clinical trial, because it's difficult to attribute causality, and it's difficult to say what this was about. And then if the patient gets better from a patient's perspective or practitioner's perspective, well, they've improved. But then we often get questions like on our IR tox team, the question is often, well, now can I safely restart? But you don't know if you can, if you didn't know what you were treating. So if it's infection, sure, you know, and we would bring that to our MDT meeting. And, you know, if we're convinced that it's infection, if a patient had a fever, if they grew something on a blood culture, that becomes easier. If nothing is going for infection, we think it's pneumonitis and it was severe, I would err on the side of saying, no, don't re-challenge, because this is a potentially fatal toxicity and the patient could die. But it becomes very difficult in those patients. And I think that's where the delay is coming from, is they're only going to ask the multidisciplinary team when the standard first-line management has failed.
So one more question, follow-up question, Dr. Naidoo. So, you know, when we look at the stem cell transplant, post-stem cell transplant complications or post-organ transplant complications, we divide them based on the timing from the treatment. So if you had to, I do remember you had shown that it is anywhere from 0 to 180 days, or even further down. I think there was one patient who was at 360 days. So if you had to pick, because we can't choose the entire spectrum, if you had to pick a zone of timing, which timing from the time of treatment, what would be the time zone in which you tend to see immune-mediated pneumonitis most often? Is there a timeline where we should be like hypervigilant about PD-L1 related pneumonitis?
So I think it's true to say that most events occur in the first 3 months. So that is, I think, the time of the most vigilance. But the difficulty is there are definitely late events. There are events like throughout the whole spectrum. So unlike, say, thyroid or liver or skin or colitis, which pretty much nearly always happen in the first 3 months, there are outliers here and a significant number of outliers. So I would say if we were going to do a screening or a monitoring or something like that, the first 3 months is probably low-hanging fruit. But in reality, and this is where the difficulty comes in, it probably needs to continue long-term. And some of even the severe events happen very late. So, so that's, I think, a little challenging.
Adam Deal has a very relevant question in the chat. Are there any identifiable factors for the development of higher grade pneumonitis that would push you to treat a patient with lower grade pneumonitis more aggressively? For example, patients with prior radiation. So just for everybody to be aware of, people who are not thinking about SCCA grading, grade 1 is asymptomatic, just found radiologically mostly. Grade 2 is symptomatic, some medical interventions indicated. Grade 3 is when you start requiring oxygen and other invasive interventions. So we're talking about grade 1 and 2 presentations. Is there some features on that which will predict, oh, this might actually deteriorate and we probably don't want to do empiric antibiotics here. Maybe we need to do a bronch and steroids right away. How do we distinguish as a clinician?
Yeah, I think actually what this question is pointing to is more the natural history. I think this question is saying, if someone has low-grade pneumonitis, are there risk factors for them evolving into a more high-grade event? And that's actually not what happens in the majority of cases. So most patients will either have low-grade pneumonitis or high-grade pneumonitis. An evolution of a low grade into a high grade hardly ever happens. So we know that only a small subpopulation of patients, when they are re-challenged after a low grade event, will subsequently develop another event. And generally, those events tend to be low grade. So if you have a low grade event and you're re-challenged, if you develop pneumonitis again, it is more likely to be a low grade event. If you're going to get high grade pneumonitis, it will tend to happen out of the gate. So it's more, are there any risk factors before starting immunotherapy that may associate with the development of high grade events rather than a relationship to low grade events? And we do know from the our original JCO paper, prior radiation, a higher dose of radiation, so definitive radiation as opposed to palliative radiation, is a risk factor. We saw that smoking status was a risk factor, and we saw that tumor histology, basically anything non-adeno in lung cancer, is a risk factor. But that's a risk factor for developing any pneumonitis, not necessarily developing just high-grade pneumonitis. The other study that I'm still working on with Dr. Suresh is, interestingly, during COVID-19, we've seen some pneumonitis, but not as much as we thought we would see. And this does indicate or lead to a hypothesis of, is there a viral trigger similar to lung GVH? You know, is this something that we have seen a little bit of a seasonal element, that pneumonitis does tend to happen in the winter? And interesting now with universal masking, okay, we still have that in Europe. I don't know what the situation is like with you, but that the pneumonitis incidence has fallen. And that I think is very interesting, and I think would stand to reason that there may be a viral trigger. So from our collected BAL samples, we're currently doing some single cell work to try to elucidate whether there is a viral element here. And I think that might be something to watch.
That is a fascinating observation, Jarushka, because I have observed the same thing for lung GVHD in this period. Yeah. And this actually is a big part of my research, is the viral etiologies of late lung dysfunction. So that, I mean, I think that is a, that observation is definitely, I think it makes sense in a lot of ways biologically as well. Yeah. So thank you for sharing that. That's I'm actually really excited to hear that. I mean, you know, it's very interesting what has come out of this pandemic.
Yeah, what we didn't expect. That's definitely
lots of things that
what I expected.
Right.
So,
right.
So can I go back to Adam's question? So I'm a little confused now. So if grade 2 does not necessarily evolve into grade 3, then we could possibly be a little bit more nuanced in its management. You know, I would probably give a week of levofloxacin to make sure it's not some sort of an atypical pneumonia or something.
Whoa. No, hold on. We want to make sure that we don't treat pneumonitis with antibiotics. So if we treat that, we think this is, say, grade 1. So grade 1 means that the patient came in for their routine restaging, they're asymptomatic, but you see interstitial lung change on your CT. So that patient, you need to either hold immunotherapy or tentatively continue and monitor their CT. That's grade 1. Grade 2 pneumonitis means that you have radiographic changes and you have new cough, new shortness of breath, new something that is leading you to a diagnosis of pneumonitis. If you think it's pneumonitis, the treatment is steroid. Antibiotic, the antibiotic is only prophylactic if you think it's infection.
How do we know it's immune pneumonitis? I mean, it's something on the lungs and some symptoms. It could very well be an infection.
Do a bronch. Do a bronch. Bronch.
Agree. Send them to us, Shailander, and we'll see them and do a bronch. I mean, these are the patients. Yeah, the grade 2 patients we see as outpatients. These are the patients we will see, and they will get a bronch.
Yes.
Like that will be our recommendation, right, Vish?
Well, Shang, I think we have to, I think there's, I like to think that hospitals are political and all politics are regional, right? And logistics of getting that done, we can discuss internally. And it sounds like we're not the only ones, but I do agree that pulmonary needs to be involved early. There's no doubt about that.
So I think,
involved early.
Sorry, Shailendra, I think to nuance that a little bit, you're not going to go straight to the bronch. So normally, if the patient comes in, you think they have grade 2 pneumonitis, you'll do an infectious workup. So you'll do a nasal swab, you'll do a blood culture, you'll do a sputum culture. You'll try to elucidate if there's something clearly going for infection versus pneumonitis. And if all of that is negative and you think this is pneumonitis, I would do the bronch if I could, if that's what I think it is. If you can't get it, then you would treat with steroids. I have an objection to treating with steroids and antibiotics because then I didn't know what I was treating. Yeah. So if I think it's pneumonitis, I give steroid. If the patient doesn't improve and then they develop infection or purulent sputum or something going for infection, then I'll treat for infection. Yeah. So I think it's just about, narrowing our differential rather than covering our differential. I don't know. What do you think?
The thing that you said, Jarushka, that I learned from just now, and that maybe was interesting to Shailander, is that these patients don't progress generally when you first see them. Because there's always this concern I have that, I'm seeing this patient early on, and they're going to progress to 3 and 4. How do I intervene now to prevent that? Am I compelled to treat now, even if it's, a grade 1?
No,
so that's interesting.
Not.
Yeah, that's very interesting.
Definitely not. Yeah.
Can I dig into a couple of logistical questions about the trial and also things that we wrestled with pulmonary here, so I can get an expert opinion?
Can I just ask one related question to this, and then we can go to that? So, how do you differentiate this grade 1, grade 2, and grade 3? What time point do you do that? At the time of first presentation? How the patient is presenting, that's what determines. And then we don't have to worry too much about grade 1 or grade 2, you're saying?
No, okay. So I should take a step back. So the grading is CTCAE. We can always do better from CTCAE, but that's what we have at the moment. So grade 1 means radiographic only. Patient is asymptomatic from a pneumonitis perspective. So usually these patients are the CT was done for restaging purposes. Grade 2 means the patient is symptomatic, but it is not interfering with activities of daily living, and they don't require invasive management. So someone is short of breath and they would require steroids. So shortness of breath, cough, chest pain, and fever are the most common symptoms, but the chest pain and fever are much rarer. It's more cough and shortness of breath, and the cough is usually a dry cough. Grade 3 means the patient is hypoxic and requires admission, usually hospitalization for IV steroids. Grade 4 means they require ICU admission, and grade 5 obviously is death. So when the patient presents to you with suspected pneumonitis is when you would grade the event.
Okay, and then the initial grades you don't need to treat, then we don't have to worry about them?
So grade grade 1, this is according to NCCA and ASCO SCCA, the sort of, and ESMO, the published national and international guidelines. Grade 1 is usually treated with drug withholding or tentative continuation of the drug with close monitoring. Close monitoring defined as visits or CT scans every 2 to 3 weeks.
Let me catch you on that a little bit. So if it's not going to progress to a severe form, why do I need to do all those things?
Because I suppose the grade that data is only from one study. That in our original memorial study, we saw that those patients never progressed, but the grade 1 patients may in effect have something else. They may have infection or something. So to continue immunotherapy is going to be potentially difficult. They may get complications related to that. So that's why the immunotherapy is generally held. And we know that further immunotherapy dosing may subsequently affect risk rather than treating with steroids. I think treating with steroids is a separate question. I think that's what this refers to is, does treating with steroids necessarily change the natural history? And treating with steroids is only for people who are symptomatic. Does that help?
Yes. Thank you very much.
Yeah. Yeah, I'll also play maybe a little devil's advocate. There might be this idea, this golden hour, right, with MI and preserving heart muscle. There's probably a correlate here of a golden week, where if you saw the patient at that point, if you maybe got pulmonary function testing, imaging, walked them and got their saturation, you could intervene and prevent a more severe event. That's a hypothesis. You would need to prove that, but I do wonder about that. I think that's what maybe a few of us are thinking about. Can I ask you about the things that we wrestle with here at our center, management-wise? Steroids, 1 to 2 milligrams. Which one do you use and why? And then 2 to 10 days of prednisone. Where does that number come from, and what do you do in your practice? Because we've tended to leave folks on longer doses, and maybe that's not quite what we should be doing.
Okay, so to be truthful, I'll try to abbreviate this very painful story, to be honest. So 1 to 2 mg per kg of the prednisone, I don't think there is any consensus here. I don't think anybody has actually studied that. Mm-hmm. So I give 1 mg per kg, but that is based on just clinical experience. That's not based on data. So I can't say that that is right or wrong. In terms of how do you define steroid refractory? Well, this is what took me 6 months to write in my protocol, and wow, was it painful. So there is no consensus as to what steroid refractory means. And to be truthful, I think similar, to the rest of the talk, it's going to be different depending on which irAE we're talking about. So where did I get this from? So I had to review the patient information leaflets of all the PD-1 CTLA-4 inhibitors to see what the data was with regard to when irAE sort of failed, when steroids failed. And based on all the patient information leaflets from the pharma companies, this is where the foundation for 2 to 10 days came from. In clinical practice, if you have a patient with severe pneumonitis, like you say, that's hypoxic on the floor or on the wards, are you really going to wait beyond 48 hours of high-dose steroids while a patient is becoming hypoxic before thinking about the next thing? So that's really based on ILD, IPF, and similar interstitial lung diseases. That's where the 2 days comes from. The 10 days, I think, is touching on this chronic pneumonitis natural history, that there are patients who have a pneumonitis or other immune-related adverse events that need longer than, say, 2 days to see a benefit from steroids. And really, I think what this is saying is that the natural history of immune-related adverse events, not just pneumonitis, is probably different with regard to how many days of steroids before you see a difference. So I think what the study is showing is that we needed a good definition for steroid refractory that is probably going to be different by the different irAEs. In the context of getting the study open, this is how it was written, but I appreciate that it probably needs to evolve. But I would say, hand on heart, if a patient's pneumonitis is not clinically improving, after 2 to 10 days of steroid, they're probably steroid refractory.
Is there, just to follow that up and then I'll shut up, is there any ever a case where you go from 1 milligram to 2 milligrams and you see response?
I don't know is the honest answer, but in my clinical practice, if someone is not, we have done that where we've gone from 1 to 2 and there's been no difference. Some people start on 2. Actually, the European guidelines say 2 to 4. I don't know where 4 comes from. I haven't seen any data with 4. In talking to my pulmonary colleagues, my understanding is that no one treats ILD with 4 mg per kg of steroid. So I think that's not sure where that came from, to be honest.
Thank you.
So there, I'll just add to that. There's almost no real data for prednisone dosing for almost any inflammatory lung disease. And for me, part of how the dose that you start with depends a little bit on radiographic burden and what you think the pattern is. So like the organizing pneumonia type patterns, we do tend to treat for a little bit longer, and that's not necessarily appropriate. I mean, so and anything above 1 mg per kg, I mean, that's pretty severe disease that at that point we're going to have to start thinking about alternative agents. But to that point, I was just curious about your about the clinical trial, and if I guess it wasn't totally clear to me where you were in that effort and
Yeah.
how far along you are with that.
Not as far as long as I would like, but isn't that the cry of every trialist? So so it took me, I don't want to be so honest, but it took me about 2 years to actually get this trial open, because again, 6 months just coming to a consensus definition of steroid refractory, and then all the operations around this, what defines a standard infectious workup? What defines a standard infectious panel? Then COVID. Do we want to include the COVID swab or not? Do you want your CT to be high res or not? Do you want contrast or not? All of these things sort of back and forth. And then, of course, the exploration of doing it through a cooperative group. I think that's honestly the only way we will be able to do a trial like this. There's no way this could be done as a single institution or a small number of institutions. But I learned a lot, I have to say, from writing this study. And I think this study is a lesson in multidisciplinary care. So I'm the overall chair, but there's an oncology and a pulmonary co-chair. And, my pulmonary co-chair is this really excellent pulmonologist from UNC Chapel Hill, Patricia Rivera, who did all of this sort of seminal work on bleomycin toxicity, and really understands this very well, and was able to sort of give great pulmonary type insights. Should we do a lung biopsy or not? Where should we do the BAL from? Right middle lobe. I feel like I'm a pulmonologist at this point from learning all of her tricks of the trade. And then, opening it in different institutions and understanding that standard panels are different across these institutions and writing it in a way that is universal to those. And then, as I was saying, our radiologist, Mizuki Nishino from Boston, she did all the radiologic element, what parameters do we want to collect from the radiology? That it's a very complicated study to write and develop, but it's now approved and open for accrual. So it opened for accrual about 6 or 7 months ago. It's open in around 8 to 10 sites around the country. And our first 2 patients have been enrolled. And of course, I know what they were randomized to, but what I can say is that one of them is still alive. So we only need 6, from one arm to identify a win. So I think it's already looking promising in one area. I was expecting just multiple deaths very quickly, but that's not what we're seeing so far. But I do think the COVID thing has thrown a little bit of a spanner in the works, that we're seeing less events than we thought we would. But maybe we'll see more of that now that immunotherapy is given in so many different tumor types and so many different settings. This isn't tumor specific, so.
Jarushka, the trial provided the drugs, right? Infliximab and IVIG.
No. So, so the infliximab and IVIG are both NCCN supported treatment options. So for this reason, this is almost like the infliximab or the IVIG will be billed to the patient's insurance. So that has been something that has been flagged before, but we haven't had a problem so far.
Yeah, I think that might be, I don't know, Shing or Wish, have you had challenges getting coverage for infliximab? Wanted to use it, any of the tricky patients?
The challenges that I've experienced are that it does take, like, it's just not, the 2 cases I was involved in, it was not given in a timely fashion because of insurance issues.
Yeah.
So that has been an issue, and I haven't considered IVIG for this.
I haven't either. And I think there's also internal challenges in terms of how we get approval internally.
Right. It's because it's a high cost medication and it has to go through specific channels for approval.
Yeah, so we had explored getting this as part of the study, but because they're NCCN compendium, this is what was thought would be easier. But I do agree that it is a challenge.
Great. Well, we are right at the 90-minute mark. I want to thank you, Jarushka, so much for enlightening us with all the work that you have been doing. I think if nothing else, it will, we hope that we can actually use this to spur discussions. And, I think we should be thinking about trials for our tricky patients, but easier said than done, as you are pointing out. But even if we can't do that, I think we can collaborate in other ways across institutions and share data and try to make a difference together. And thank you for your leadership on that. Just as a reminder, all the participants will get a link for a survey at the end of it. Please share your feedback, any suggestions for future topics and speakers. And with that, we can call it off. I'm happy to stay on if people want to carry on a conversation here. Our SCCA team, if you don't mind, maybe making me the co-host, and you can hop off if you need to. But again, thank you so much, Jarushka. I appreciate it.
Take care. Thanks, everybody. Okay. Hi to everybody in Seattle. Take care. All the best. Bye.
Bye-bye. Do you want to just use the Zoom call and maybe we can chat about it?
Yeah, that sounds good.
And Ritu, Carrie, can you maybe make the co-host if you need to hop off?
So Dr. Bhatia, I just made you the co-host and I'll just, stop the recording.